Okay, friends, I am Dr. Ajay Yadav. So let's start today recall questions. And more or less, I will say anesthesia questions were not that easy. However, not tough also. But yes, of course, you if you would have read anesthesia, then you would have been able to answer the questions. So anyway, let's start. So, okay. Question number one. A patient is scheduled for laparoscopic surgeries under general anesthesia in a daycare setting. Which of the following factors make him unsuitable for daycare surgery? Home is 45 minutes away drive from the hospital. The surgical procedure is expected to last slightly over 1 hour. No attendant is available at home to care for the patient post-operatively. ASA grade 3. Uh, Okay, so we'll come back to this question, and so let's first discuss about daycare surgery, and when we'll come back to this question. Patient or surgery selection. Surgery, there is as such, if you ask me, no list of the surgeries which should be performed on daycare basis. It depends on every institute, and every institute has its policy. Based on that, they decide that which surgeries can be performed under daycare. However, yes, you can say, I'm telling you the latest guidelines, that the surgery of the moderate duration. Moderate duration definitions means in and around 90 minutes. It is not hard and fast, but you can say in and around moderate duration, say 90 minutes. As far as patient selection is concerned, which patient? Patient with ASA grade 1, and ASA, you know, is the American Society of Anesthesiologists, which classified patients on 6 categories based on their medical condition. ASA 1 is healthy patient. ASA 2 means patient is having mild disease that is not causing functional limitation. ASA 3, the disease is causing functional limitation. 4, the disease is severe that it has made patient line incapacitating. 5, moribund, and 6 is brain dead. So ASA 1 safely, ASA 2 safely. Now ASA 3 also has been included, and there is a change. Previously, we were including ASA 3 for whom disease controlled for 3 months. But now that has been changed. Now they say if the patient disease is controlled, means patient is diabetic, hypertensive. But you see that today when the patient came to you, his sugar is controlled, blood pressure is controlled, means patient can be easily considered. And patient coming alone again is an exclusion. So must be accompanied by attendant. It is a rule from the beginning. Means patient must have an attendant, then only we can consider the patient for daycare surgery. Patient coming alone cannot be considered for daycare surgery. Then drugs, which are the drugs which we can give to the patient. You can give general anesthesia, you can give regional anesthesia. So regional anesthesia is not a contraindication, means any kind of block, including spinal, can be given for daycare surgery. GA, which drugs you should prefer? IV induction agent is propofol. Inhalational agent is sevoflurane. Muscle relaxant, which you are supposed to use, is mivacurium. Benzodiazepine is midazolam, and opioid is remifentanil. So these are the groups of the drugs which you should select for daycare surgeries. Now, other criteria is the discharge criteria. So there are many discharge criteria. but vitals must be stable for more than 30 minutes. Means continuously vitals should be stable for more than 30 minutes, then you can only discharge the patient. And of course, needless to say, there should not be any bleeding and there should be an attendant. And we generally ask the patient to be near the hospital. Patient should be near the hospital so that if there is as such no, you can say distance time, because it depends on area to area. In India, some cities, even if the patient is 5 kilometers away, it can take 5 hours, Indian cities. So they say it should be near to the hospital so that if there is a requirement, patient can be immediately brought to the hospital. Now, with this background, now let's go back to our question and discuss the question. So, which of the following factors makes him unsuitable? That means unfit for daycare surgery. Okay, home is 45 minutes drive away from the hospital. We'll keep this option just with yes or no. Surgical procedure is expected to last slightly over 1 hour. We can take the patient up to 90 minutes, I told you. So this is a suitable patient, not an issue. No attendant is available at home to care the hospital for the patient post-operative. This is obviously unsuitable. This I will say suitable or unsuitable, both I'll keeping this for right now. ASA grade 3 nowadays I told you can be taken if the disease is controlled. So 3 can also be taken. So of course this is suitable. So D and B you can easily rule out. Now the choice between A and C. This is an absolute, I will say, contraindication. Patient having no attendant cannot be considered even from the beginning from the daycare surgery. This is rule we exclude even in the beginning of the surgery. No attendance means patient cannot be taken. Who have to take care of the patient in the hospital, take the responsibility of the taking the patient to home safely and taking care of the patient at home. And if there is, we give instruction to that attendant. If you see these sign and symptoms of the patient, immediately bring back to the hospital. So considering these, of course, C should be the best answer. Home is 45 minutes away from the hospital. I will say if it is a multiple choice question, I will also go for this option too. But so I don't know, it's a recall question. So it is exactly correct or not. We will discuss this during our discussion, no problem on YouTube. You can post your queries. But patient's home, they say should be near, very near. So if the complication happens, patient can be brought to the hospital. So this question, either there is some problem in recall or let's see. So what we got options from that, we can say C. However, I think there is some thing which is missing in this question. We'll come back. Let me see if you had connected. Let me connect and let me see if some of you had posted anything on till now. Nobody has posted any query. Okay, no problem. Later we'll see to it. In the image shown, identify the function of the marred structure on the tracheostomy tube. However, the question what I got initially, they were showing endotracheal tube. So of course it is not endotracheal tube, it is tracheostomy tube. Facilitation of vocal cord visualization, monitoring airway pressure, prevent aspiration, suctioning of the lower respiratory tract secretions. So this is cuff of a tracheostomy tube or endotracheal tube is used to prevent aspiration. I know some of the people, they think that the cuff of endotracheal tube is inflated uh, so that tube doesn't come out to avoid accidental extubation, but that is not correct. The cuff of endotracheal tube or tracheostomy tube is filled only to prevent aspiration. To prevent dislodgement of the endotracheal tube, we have to tightly secure the tube at the angle of mouth with adhesive plast. Now let's discuss some of the very important thing about cuff you should know. Aim, already I told you, just to prevent aspiration. That's the aim. Then cuff pressure, too high pressure will cause tracheal injury, too low pressure will cause aspiration. So cuff pressure should be kept between 15 to 25 centimeter of water. So that should be the cuff pressure. And then another very important thing, previously for children less than 10 years of the age, we were not using cuff tubes. But now for any age, we can use cuff tube. Even for a child, we can use cuff tube. Previously, we were not using cuff tube in children, considering that this cuff is going to be inflated in subglottic area. But this concept does not exist. So cuff tube can be used in children at any age except prematures. Prematures, we still do not use cuff tubes, but otherwise, even to a newborn baby, it is allowed to use the cuff tube. So, of course, the cuff is used to prevent aspiration. Question number 3. A patient under surgery develops malignant hyperthermia. He is RYI1 positive. It involves which channel? Sodium, calcium, potassium, uh, and calcium. Okay. Then, okay, let's discuss malignant hyperthermia. Very, very important topic. Why malignant hyperthermia occurs? This is an abnormality of the ryanodine receptor. And ryanodine receptor, you know, is a calcium release receptor. The abnormality of that leads to accumulation of calcium in sarcoplasmic reticulum. And this accumulation of calcium will cause sustained muscle contraction, and the sustained muscle contraction will increase the muscle metabolism. That will cause hyperthermia. So ryanodine receptor abnormality leads to accumulation of calcium in sarcoplasmic reticulum, and that leads to sustained muscle contraction, and that produces heat, increased muscle metabolism, and that is responsible for hyperthermia. Causative agents in anesthesia, the most common causative drug is succinylcholine. Succinylcholine, or you can say succinylcholine. Then all other than succinylcholine, all volatile agents means volatile inhalation agent, that is halothane, isoflurane, sevoflurane, desflurane. So all volatile agents can trigger malignant hyperthermia, but most commonly it is seen with halothane. So all volatile agents, they can trigger malignant hyperthermia. Most commonly it is seen with halothane. Clinical features, there will be rapidly rising CO2, and CO2 can rise so much that it can goes even 80 to 90 mmHg, means almost double, more than double. Then of course you will expect hyperthermia, and malignant means very rapidly and very high. So temperature can go as high as 108 or 109 degree Fahrenheit. Then you can expect acidosis because so much metabolism is increased. Then hyperkalemia is a very, very important feature. And hyperkalemia can induce ventricular fibrillation, which is the most common cause of death. Generally, we think that the most common cause of death in malignant hyperthermia is hyperthermia, but that is not correct. The most common cause of death in malignant hyperthermia is hyperkalemia. Management, specific management, is dantrolene sodium. So dantrolene is a specific drug which act as sarcoplasmic reticulum, preventing it release of calcium from sarcoplasmic reticulum and thus treating the malignant hyperthermia. Safe agents, if you are giving anesthesia, propofol, of course, is safe for induction. Maintenance, we cannot use volatile agents, so intravenous opioids are being used. And muscle relaxant, needless to say, suxamethonium is contraindicated. However, other muscle relaxant that is non-depolarizing of muscle relaxant can be safely used. So that's all about malignant hyperthermia that you should know. And the question was actually very easy. RIR positive means patient is having patient is a case of malignant hyperthermia. So obviously it is the abnormality of the calcium channels. Question number 4. A patient under anesthesia is found to be in a cannot intubate, cannot ventilate scenario. What is the next best step in management? Administer succinylcholine and retry intubation. Cricothyroidotomy, insert a supraglottic airway device, wake the patient up and nasal airway. Okay, so I'll go to the details of this question because that is the most disastrous situation I can say. Cannot intubate and cannot ventilate. Okay, I think let's just let me add one slide to it. So patient is, I can say, difficult intubation, or other word, I will say patient is actually failed intubation. Not only difficult, means you tried intubation and you have failed. You're not able to intubate the patient, failed intubation. Now there are two scenarios. Can not intubate but can ventilate. Means you're not able to intubate, but you are still able to ventilate the patient with bag and mask. So this is a safe situation. Means no problem, you're not able to intubate, you're still able to ventilate the patient. So at least patient will not die of hypoxia. So it definitely not a very life-threatening situation. So here what we will do, we will retry intubation. But doesn't mean that retry intubation in the same scenario. After changing position, maybe your position is wrong. What is the position for endotracheal intubation? Extension at atlanto-occipital joint and flexion at cervical spine. So you may not be able to intubate because your position is not right. So after changing the position, change your laryngoscope blade, or if you have facility, you can use video laryngoscope, which can significantly increase the possibility of intubation, or you can use stillet. You can put a stillet in the tube. So maybe your tube angle is not proper, larynx is anteriorly placed. You can use a stillet or you can use a bougie. Bougie is rigid, so you place the bougie, and over that bougie you railroad the endotracheal tube. So you can try all these things, but you are able to, when you try with changing position, not able to intubate, no problem, ventilate for some time, oxygenate the patient, but maximum they say is 3 attempts. 3 attempts you can try. Or if still not, if you are still failed, then you can try laryngeal mask uh, airway, LMA, that is a supraglottic device. You can try doing the surgery with LMA if it is possible, fitting LMA nicely. You can use LMA. Or even if that is not fitting, that you are failing, then you have to awake the patient and plan for fibro-optic intubation. Wake up the patient, let the patient to wake up from the effect of muscle relaxant, and then you know that it is a difficult intubation, then you plan next time when the patient is awake and you try awake intubation. So this is one situation. Now, second, the most disastrous situations is cannot intubate and cannot ventilate. Very disastrous situation. So if you're not able to ventilate, patient will die. So here also they say, if your situation is permitting, like say you're not able to ventilate, but still you are seeing that the patient oxygen saturation is still say 98%, 99%, means patient has not yet become hypoxic. So here you can go for one attempt again. One attempt by using say changing the position or using video laryngoscopy if everything is ready. So one attempt, but that again I will say is optional depending on the scenario. Else, the best is you just put the laryngeal mask airway. LMA. LMA, laryngeal mask airway, is a supraglottic device. If you're not able to intubate, you can place laryngeal mask airway and maybe ventilate. So mostly you will be successful. Mostly. And this is a common scenario we see, not able to intubate, put LMA and ventilate. So at least that situation of ventilation goes. Mostly I will say you are successful. If not, then you have to go for an emergency life-saving procedure like say needle cricothyroidon. It is the least preferred, but you cannot let the patient to die. So if you're not able to ventilate the patient with LMA also, then you are not left with any option. You have to go for needle cricothyroidon. So now let's go to this question. Cannot intubate, cannot ventilate. Okay. Administer succinylcholine. Of course, you have already given muscle accent, so I don't think you will be already not able to ventilate. So if you are not able to ventilate after succinylcholine, also not be able to ventilate, and patient will die. So that is ruled out. Cricothyroid mean not the best step. It is the last resort, so that will also be ruled out. Insert a supraglottic airway device. Yes, this is best. And wake up the patient. Wake up the patient is not in your hand. If you are not able to ventilate the patient will die. He will never wake up. So you have to put supraglottic airway device. See. So let's discuss a bit about supraglottic air devices, that is laryngeal mask airway. So this is a classical laryngeal mask airway, and I'll show you also this. So how it works? It is just placed blindly. You just place blindly and inflate with a large volume of air. So this cuff will get inflated and will seal the oropharynx and hypopharynx from all sides because we have inflated the cuff. And then you ventilate through this tube. You can see these holes, ventilation holes. Now air cannot go anywhere. So because you have sealed the oropharynx, hypopharynx, so air will automatically reach the larynx and patient will get ventilated. So basically this LMA, the main advantage when it was manufactured or synthesized was as an alternative to failed or difficult intubation. This was the basic, you can say, indication for putting LMA. And that's the chief advantage. However, over the years, we have used LMA so many times. Now we are using it even for elective ventilation because we are confident that we will be able to ventilate the patient. So we are using it for elective ventilation. So this is a classical LMA. Now the disadvantage of classical LMA is that, see, even if you have placed it oropharynx, but still there will be some leak from the sides. So air can enter esophagus, increase intragastric pressure. So there is increased intragastric pressure. So there is increased risk of aspiration. So that is one of the disadvantage of LMA, you can say. There is increased risk of aspiration. And the problem is that you are clearly seeing that patient's stomach is getting distended. Still, you will not be able to deflate, because from where you will pass your suction catheter Ryle's tube, because cuff has occupied the oropharynx, laryngopharynx. So therefore, nowadays we are using second generation LMA. And the prototype of second generation LMA is ProSeal. So can you see ProSeal? So second generation LMA, they have the separate port for stomach decompression. They have separate port for stomach decompression. Can you see this port? Through this port, we will insert a Ryle's tube or suction catheter, which will enter the esophagus, and you can deflate the stomach. So this is ProSeal, which is classical type. Then this is LMA Supreme. The angle is different, so it is easy to insert. Then one more LMA which is very commonly used in India is iGel. So the cuff is already filled with gel, so that's why name gel. So advantage means there is no possibility of accidental deflation of the cuff, so that cuff related problems can be easily avoided. So this is also very commonly used in India. So there are so many types, but these are the very common ones and basic that you must. So now it is very much clear that the main indication is for alternative to failed or difficult intubation. So in this scenario, we're not able to ventilate, not able to intubate. So LMA come actually as a savior. It comes as a savior. Okay. A patient was intubated and was on mechanical ventilator for weeks, developed inspiratory stridor. Which narrowing would have been the cause for this? Although it is more or less a physiology question, so maybe would have been discussed in physiology, but since the patient is on mechanical ventilator, so I think they gave this question to me. Glottic narrowing, subglottic narrowing, supraglottic narrowing, bronchial narrowing. See, inspiratory stridor is typical of upper airway obstruction. Upper airway obstruction, and upper airway obstruction means you can say more or less as the glottic opening, glottis. So, and this is common on ventilator patient actually. This is common on ventilator patients. Chronic ventilator patients for weak, obviously they develop vocal cord edema or even little subglottic edema also. So actually, honestly speaking, again, I don't find this question to be appropriate if you will ask me, because upper airway obstruction, not only it is a glottic opening, even little subglottic opening is also considered in upper airway, or even little supraglottic pharyngeal is also considered as upper airway. So any of these, but since if you have to choose one, then I'll go for glottic, or I don't know, the question would have been except, then it makes more sense to me, and then it will be bronchial narrowing. Bronchial narrowing, or you can say distal airway narrowing, will be accompanied with expiratory obstruction like COPD or asthma. There occur expiratory obstruction, not inspiratory. So inspiratory obstructions means upper airway, and upper airway more or less include all this. So I think this question ideally should have been except, then answer would be D. But if it is question is like that, then it is really, if you have to choose between supra, sub and glottic, then we'll be choosing glottic. So I don't know what is the exact question. We'll just discuss with you on YouTube and let's see what is the error. Question number 6. During GA, which nerve is most commonly motivated during a nerve stimulator to assess neuromuscular blockade? Radial, ulnar, median, tibial. I'll just come back to this question. Neuromuscular monitoring. Of course, detail is not expected even at undergraduate level. So what you need to know in neuromuscular monitoring is that ideal muscle for monitoring are corrugator supercilii, or orbicularis oculi. Both are supplied by facial nerve. However, and why they're ideal? Because their action parallels with the laryngeal, because head and neck muscles go together. So if you are not seeing any response in orbicularis or oculi or corrugator supercilii, or there's recovery, that means laryngeal pharyngeal muscles have recovered. But practically it is not possible to apply these electrodes over eyelids. So it is not practically not used. So therefore, most commonly used is adductor polysis, which is supplied by ulnar nerve, which is supplied by ulnar nerve. And why adductor polysis? You can clearly see here enough space to apply electrodes to stimulate the ulnar nerve or the medial side of forearm, and then you can see the thumb movements, because once you stimulate, ulnar adductor will be stimulated, and that will move the thumbs but not need to see the movement. We do the uh, monitoring with some parameters. Of course, all those details are not required for you. So there are many parameters. So what you can remember is that the most commonly used is adductor pollicis muscle supplied by ulnar nerve, and that is what they have asked in this question also. So it is ulnar. So even at looking at the electrodes, you can see, if you don't know also with common sense. Ulnar is on medial side, radial is posterior, and median will be, of course, on the lateral side or at least in the middle. And tibial is obviously in the leg, and this is a photo of hand. So even with common sense, even if you don't know, you could have answered this question right. Okay. And the waveform shown in the image represent which of the following physiological parameter? Arterial oxygen saturation and tidal carbon dioxide, functional residual capacity, tidal volume. I think they have already given the answer. So even if you don't know, although this is the easiest question among all questions we have discussed so far, if you will ask me, that this is capnography, measurement of end-tidal carbon dioxide. What is capnography? Which is the measurement of end-tidal carbon dioxide with graph. And the normal value is normal PCO2 is 40. So just 2 to 3 mm less the 2 to 3 mmHg less than arterial PCO2. So I can say around 38 to 42 mmHg. Arterial PCO2 is 35 to 45. So just 2 to 3 mmHg less than that. So this is a normal and tidal carbon dioxide. So you can copy it from the graph image. But I like to discuss a bit about capnography because this is very, very important. And you have seen in FMG, like if I see the pattern of 10 years, every year there's a question on capnography. But this time I will say the easiest question, otherwise it is always on one of the abnormal graph. Question on LMA, one or other way. Today they ask in a very nice clinical way, cannot intubate, cannot ventilate. Then question on malignant hyperthermia is always there, and this time also I will say they asked you the easiest question related to malignant hyperthermia. So these 3 4 topics I've seen every FMG exam there is a question on this, and this is a very good thing that these are very important topics that you must know. But luckily this time I will say the easiest question. Uses, it is the surest confirmation of intubation. If it 100% confirm that your position of the endotracheal tube is correct, or you can say place your tube in esophagus. So if your tube instead of endotracheal tube goes in esophagus, means that means you are directly killing the patient. So your CO2 will come out of endotracheal tube only if the tube is in trachea. Expired. Antidal means expired. So it will come out of endotracheal tube only if the tube is in trachea. If the tube is in esophagus, from where the this carbon dioxide will come out. So it confirms surest confirmation of intubation. So we'll see some graph, and accordingly we will see the uses. The normal graph for a controlled breath. Controlled breath, you know what is the meaning of controlled breath? Means you or ventilator is delivering the ventilation to the patient, and that is the usual scenario because we are giving muscle relaxant. So this is the normal graph, and that is what you have seen is the control breath graph. Fine. If the patient is spontaneously breathing, spontaneous ventilation, then you get this kind of graph, which you can say is sort of hill-shaped graph. It will be of a hill-shaped graph. This is spontaneous. So these are the normal graphs. Now, common abnormal graphs we see. If you get this kind of graph, means it's a normal, say, control graph, but you see a notch. This notch is called as curare notch. So what does this indicate? That indicate spontaneous breath during controlled ventilation. I told you how we achieve controlled ventilation by giving muscle action. When the effect of muscle action off, patient will try to take a spontaneous breath, which will be represented as curare notch. So this is common. So that means we have to repeat the dose of muscle relaxant. So even when to repeat the dose of muscle relaxant can be decided by capnography. Exhausted soda lime. You know, soda lime is used to absorb carbon dioxide. So expired gases pass through soda lime. Soda lime absorb carbon dioxide, and the same gases can be reused. So if soda lime is exhausted, so this CO2 will come on the inspiratory side also. So it will never reach the baseline. Say during inspiration, if I show you the part of capnography, this normal capnograph, see, this is the point where inspiration begins. Until here, all this is the expiration. So all this is the expiration. This is the point when inspiration begins, CO2 should fall back to zero, coming back to zero. But if patient is inhaling carbon dioxide, then it cannot come back to zero. It will be higher than zero. So it indicates that soda lime is exhausted. So we have to change the soda lime. So we can decide to change the soda lime by looking at the capnograph. Bronchospasm, what you see in bronchospasm, expiration is prolonged. So this is expiration. So this is all expiration. So it will be prolonged. So what kind of graph you will see? That expiration will be prolonged. So the shape of the graph, it little more clear. Graph will be there. Then expiration will be prolonged. Prolonged expiration, and that look at the shape of the graph. It is like shark fin of the shark fish. So shark fin pattern is indicative of bronchospasm. So you can detect bronchospasm with capnography. Malignant hyperthermia, if you remember, I told you that CO2 can go very high, 80, 19, 80, 90 mmHg. So what kind of graph you expect in malignant hyperthermia? CO2 will start to rise, will keep on increasing. And after some time, you know the capacity of soda line to absorb CO2 will exhaust. So the baseline will also start shifting. And more CO2, more baseline will shift up. So this is a step ladder pattern. So step ladder pattern indicates malignant hyperthermia. And in fact, before the patient develop hyperthermia, we have already diagnosed malignant hyperthermia by looking at capnography. So capnography is the earliest indicator to detect malignant hyperthermia. Then flat line, the most disastrous complication. CO2 was coming nicely, like normal graph. And then you see there is no CO2, flat line. And value on monitoring of EtCO2 start to show you zero. What does that mean? That means tube has slipped out. Accidental extubation. If tube is not in trachea, from where CO2 will come out, that means tube has extubated. So extubation, many people generally think means tube has come out. No, it has come out of the trachea and may have slipped into esophagus or may be present in pharynx. But still CO2 will not come. So if you find this graph, external extubation should be the first thing that should come to your mind, or ventilator failure. When there is no ventilation, how CO2 will be generated? So again, it is going to become zero, or disconnection of endotracheal tube from circuit, breathing circuit. You are ventilating the patient with breathing circuit, and if it get disconnected, how CO2 will reach the monitor? So again, it will become zero. So these are the common conditions which are life threatening, which can be detected within seconds with capnography. If you only rely on pulse oximetry, it will show you oxygen desaturation even when the reserve of the oxygen body get finished, means after a few minutes. And with capnography, you can detect these complications within seconds. So capnography is an excellent monitor which give you detail of every breath. So now you can understand that this is a graph of end-tidal carbon dioxide. So that is all the question they sent me. Now let me see, go to my chat box and see any question which we have found doubtful. Not seeing any query. So let me wait for one more minute. If I get some query, fine. I'll close the session. I'm not able to see the messages. I don't know, because I'm seeing 5 messages, but still I'm not able to see the messages. Any doubt? Seeing any message? No problem. If you have any doubt later, you can ask us, and you see, we are always there to help. Or Insta. Okay, then. Thank you very much, and my best wishes. So I am signing off. No problem. If you have any doubt later,